Hi, everybody. Thank you so much for joining us for tonight's webinar. My name is Allison Feldman. I work for the Facial Pain Association. Hosting tonight's webinar is going to be Ann Simnecki. She is one of the Facial Pain Association Board of Directors. She is also a virtual support group leader, a peer mentor. She wears many, many hats in the facial pain community. She's an author, presenter, sometimes conference host. So I'll turn it over to Ann in just a minute. I just want to make a few short announcements. Our new website is up and running. It is facepain.org. You can find all of our past webinars and Facebook Lives on our new website. So we hope you will take a visit to our new website and check those out. Our next webinar is going to be on Wednesday, July 21st. At 7 p.m. Eastern Time. Dr. Lisa Scott Morrow will discuss anxiety in people with facial pain. This webinar will introduce brain mechanisms that are involved in the experience of fear and anxiety, including discussion of why these mechanisms interfere with concentration and mental clarity. You can register for that on our website as well. FPA is recruiting volunteers. If you are interested in volunteering for the Facial Pain Association as a support group leader or co-leader, a peer mentor, a social media ambassador, or just want to learn more, please contact Regina Gore and you can reach out to her on info@tna-support.org. Again, you can give us a call, contact us at the office, and we will direct you to Regina. The Facial Pain Association is a registered 501c3 nonprofit organization. Your donations, your support is so much appreciated. It makes a real impact on our ability to continue to provide these free programs. So you can, again, go to our website. If you need any assistance with making a donation, we are happy to help. And without further ado, I'm going to turn it over to Ann Simnecki.
Hey, thank you, Allison. It is my absolute pleasure tonight to introduce you to my doctor, Dr. Larry Arbeitman, who I now consider a friend of mine since we've been seeing each other for 10 years. He's going to be telling us about a very conservative approach to managing facial pain. And that approach, of course, is Upper Cervical Chiropractic. Specifically tonight, you're going to learn what Upper Cervical Chiropractic, or UCC, is, how it differs from traditional chiropractic techniques. It's not the old bone cracking thing or image that some of us have. We're going to talk about the connection between the upper cervical spine, which is just C1 and C2 over here, with facial pain. We'll talk about some research and case studies. And you'll learn what kinds of outcomes you can expect and how quickly you can expect to have them. We'll also talk about how to integrate upper cervical chiropractic into your global medical care for facial pain. And we'll talk about how to find an upper cervical chiropractor. I'm going to spend a minute or two because I think it's important to tell you about my story. I first heard about upper cervical chiropractic before I needed it back in 2008 at the Detroit FPA conference. And there was an upper cervical chiropractor on the program. And I was thinking, I'm not sure I believe this, but I'm going to keep it in my back pocket. By then I had had 2 MVDs, a Gamma knife, taken every drug in the book, and probably tried every other CAM modality that you could think of. I was beginning to get bad flares again, and I had to increase the amount of medication I was taking. And I increased that to the point where I could not safely drive a car. And that really hampered me. So I started thinking about what else I could do. And I remembered back to the conference, and it was so long ago that I looked in a phone book and found Dr. Arbeitman. I called the office. They treated patients with trigeminal neuralgia. and I very skeptically went in. Do you remember that?
I do. I do.
It's probably the most skeptical person you ever had. But I gave it a try, and not immediately, but within a couple of weeks, I found that I was down to my prior level of medication and I was able to do things again. So one of the first things I did was go out and buy a new car, which I'm still driving 11 years later. And it was just a wonderful thing for me to get parts of my life back. Now, was it the magic bullet? No, because there is no magic bullet. We need to have lots of tools in our toolbox to manage this condition. And upper cervical chiropractic is just one more, and a very conservative one and very easy one at that. So without any further ado, Dr. Arbeitman, take it away.
Thank you. Thank you. I've got to say, having done many presentations in front of people, this is still very strange to be speaking to my laptop. So I want to thank Allison for all the work you do behind the scenes to get this information and providers in front of people who need it, who need information. And Anne, I want to thank you for your trust and confidence for over a decade now. And yeah, I remember our initial intake, and I remember you were on so much medication, you were literally walking the walls. You had to hold on to the wall to walk down the hallway. So the day that you showed up with that red Mazda Miata and we looked out the window into the parking lot, that was a big success for you and for us as a team, because I do view us as a team. And it's an honor. It's an honor to be here with everybody. I'm going to bring up my presentation. And I just need a head nod. Anne, can you see this slide?
I can. And can I just say one more thing before you continue?
Sure.
If you have any questions, please put them in the chat, and I'll be monitoring the chat as we go along, and we'll have plenty of time to answer your questions at the end.
Yeah, I'm going to go for about 30 minutes here, so we have plenty of time to handle any and all questions, and Anne has a list of common questions as well. And so when I was asked to, well, we've come a long way. So after Anne and I started working together, we decided to start a support group at our office, and we would meet once every couple months. We would bring practitioners in. And what was always shocking was just the amount of people in the local community that suffered from different versions of facial pain. And we ran that support group for quite a while. There was a great opportunity for us to speak at Beth Israel at one of the regional conferences. So Anne and I have been involved working with facial pain patients for quite some time. I find this is, for me professionally, very satisfying to be on here with all of you today, because most of you, I would assume, are in another area of the country. We're in New Jersey. And if something I can say tonight can turn you on to this wonderful type of healthcare, and I don't know, the way my mind works, I almost see somebody going to find a doctor, getting the help that they need. Maybe it's a young person that has a life-changing experience with upper cervical care. Maybe they decide to become a chiropractor, an upper cervical chiropractor, and go on to save, hundreds and thousands of other people from suffering. And so maybe just one of you, if I can get through to one of you, but if I can get through to 25 of you, even better. And so I take this as a privilege, and I'm going to give you all I got tonight. So a little bit about me, like, why should you listen to me? Who am I? I am an upper cervical practitioner. I practice in Marlboro, New Jersey, which is about an hour south of New York City and an hour north of Philadelphia and 20 minutes from the beach. We've done over 300,000 spinal corrections in our office. I've trained 15 doctors in my practice since 2003. I did write a book called The Gift of Hope, The Path to Healing Through Upper Cervical Chiropractic. And you can download an e-version off of my website, which is at the bottom of every slide, and just fill out the little form that's on the homepage, and you'll be able to download that free of charge. I also had the distinct honor and pleasure of helping with Chapter 11 of the Facial Pain Association's book, on upper cervical care. So really proud of that. And our approach has, as Ann alluded to, has always been a multidisciplinary approach. I think that's just good healthcare. Obviously, the goal for everybody is to go least invasive first and then move up the ladder as necessary. Oftentimes, by the time we meet somebody, they've kind of gone through a lot of their medical options, and then they kind of circle back and check in with us, the conservative option. But some people are looking at potentially having an MVD, and they want to just do everything they can prior to doing something as invasive as that. I'm also an awesome husband and father. I always got to say that because there is a human being that comes inside this doctor. And my kids' names are Jade, 10 years old, and Easton's 6.5. And they certainly motivate me to do a good job for all of you. So we're going to talk about what is this connection between the spine, a chiropractor, and facial pain. For most people in the general public, I get it. Like, isn't the chiropractor like the bad back and the bad neck doctor? And yes, we help people with bad backs and bad necks, but it's a lot more than that, specifically when you were an upper cervical doctor. So when you look at this x-ray, and I know that we don't have any radiologists on the other side of the Zoom call, but you can see very clearly that spine isn't straight. The hip on the right is very low. The spine has a big curvature in it. The head and neck are tilted and twisted. And what you've got to realize is this person has trigeminal neuralgia and epilepsy. And so the center of that being is the spine, and the spine is the central axis. We live our life through our nervous systems. That's why this is such a horrible condition at times, because it just takes over our awareness of our body and our environment. And so our health is only going to be as good as the structure. Structure dictates function. If you bought a house like this or a car like this, it may not work the way that it was intended to. And so when we think of chiropractic, we have to recognize that there's a lot of misconceptions. We're not physical therapists. We don't do therapy. The way that I explain this is there's 3 layers to the body. You've got the muscles and the tendons and the ligaments, the soft stuff on the outside. Then you got the bones in the middle, and you got the nerves on the inside. We specialize in the bones and the nerves. The therapists, the trainers, the massage therapists, they work on the muscles, tendons, and ligaments. And they're great people, and they're wonderful people. And they may even be able to help people who suffer with facial pain. I don't know. But what we do is very different than that. What we don't do is in upper cervical care is we don't crack, pop, and twist the spine. And we're going to talk in a bit about what it is that we actually do. And so our focus, as I've kind of alluded to, is the nervous system, the brain and the spinal cord, and recognizing that the structure dictates the function. If the structure is off, the nerves within that structure aren't going to fire and operate properly. And it could affect what comes out of the brain and into the body, the messages, but equally it could affect the messages coming back to the brain. And so at any given point in any day, and I actually looked this up, it's 11 with 13 zeros after it. I don't even know how to pronounce that number. Bits of information per second are filing out of the brain and into the body. And most people think the brain is telling the body what to do, but the brain is actually a sensory receiver more than it is a teller. It's actually constantly picking up information from the body, perceiving it, and then sending information out based on that perception. If that perception is off, it can come back as pain. It can come back as altered behavior. It can come back as altered emotion. It can come back as altered function. Now, there's one area that all those little yellow dots have to pass through on the way to the body, and that's the upper cervical spine. Everybody knows that the upper neck controls the whole body, including the face. I mean, if we think back to the tragedy of Christopher Reeves, when he injured his upper neck, it didn't just affect his neck, it affected his whole body. So yes, the upper cervical chiropractic approach is a full spine and full body form of healthcare system. But however, we've have great experience, clinical experience and research working with patients with facial pain because of the location of the work that we do in the upper neck. And we're going to go through some of that anatomy right now. So most of you who are struggling with some sort of facial pain are probably aware that there's 12 cranial nerves. There they are. They come off of the brain stem. The brain stem is your mind-body connection. This is where your brain meets your spinal cord. And the fifth cranial nerve is the trigeminal nerve. It's the one right here in blue that says trigeminal. And you can even see the 3 branches that most of you probably know about. So those 3 branches, just an anatomical review, V1, V2, and V3, go to different distributions in the face. V1 being the forehead, eyes, nose, and scalp. V2 being the cheek and the upper lip. And V3 running along the side of the face and into the mandible. We call them, anatomically, we refer to them as the ophthalmic branch, the maxillary branch, and the mandibular branch. This isn't any new information for those of you who have been, researching on your own. But what's interesting is most people that are driven for help for facial pain are feeling sensation. So that's the sensory information that I was talking about coming into the brain. But the trigeminal nerve also has a motor function where it actually controls the muscles of mastication, or the muscles that move our mouth and chew our food and help us talk. So there's 8 muscles. They control 8 muscles, and 4 of the muscles are our mastication muscles: the masseter temporalis, and the pterygoids. It's not uncommon for TMJ issues to develop with people with facial pain or upper cervical issues because of this trigeminal nerve connection. And a lot of people end up at the dentist first, thinking that they obviously have dental issues or TMJ issues, and sometimes it's both end. So one of the mechanisms for facial pain is this neurovascular compression, where there's a blood vessel putting pressure onto the trigeminal nerve, causing a hyperactivity or an irritation to that nerve and firing that nerve off. It requires a specialized MRI to find that. And then most of you may have heard there's a procedure, and Anne alluded to it, the microvascular decompression, where they go in and they separate the vessel off of the nerve. They wrap the nerve to create a separation or a barrier. And there's certainly a level of success with that when they find that. But there's also times after all of that, with time, that the symptoms can return. So, excuse me, that's why I have water. It's the end of a long day of talking. So how could the symptoms return if that separation was made by a physical barrier? Excuse me. And that's because even though pain is experienced in the face or felt in the face, it's experienced in the brain. And that message has to pass from the face through the nerve to the spinal cord and up to the brain. And what about those instances when they do the MRI and they don't see the blood vessel on the nerve? Then what? What are some of the other mechanisms? We're going to talk about those mechanisms. So the spinal trigeminal tract. A tract is basically the path of the nerve within the spinal cord. So that nerve, those nerves in the face can get traced all the way back to the brain stem, where I showed you that nerve originates from. But the nucleus, where all those nerves originate from, go all the way down to as far as C4. And I remember when I spoke at Beth Israel at that regional conference, and I talked about this idea of trauma to the cervical spine can irritate the origins of the nerve as low as C4. The neurosurgeons came up to me afterwards and said, wasn't even on my radar. Thank you for bringing that up. Not that they weren't aware of it. It's just we're all hyper specialized in what we're focusing on. And so when we look at this nucleus, or where this nerve comes from, I oftentimes, when teaching this concept to patients, talk about facial pain as being sciatica of the face. Most people are familiar with sciatica. That's that horrible nerve pain that runs down the back of the leg, oftentimes from a herniated disc or stenosis in the lower back. And sometimes it's not even felt in the back. It's only felt in the foot or the ankle. How can that be? And everybody knows that that leg pain and that foot pain is originating from the lower back, that sciatic nerve comes out of the lower back and runs down the spine. So an irritation at the lower back can cause leg pain, just like an irritation in the upper neck can cause facial pain. It's really no different. The trigeminal nucleus extends through the entire brainstem from the midbrain to the medulla, which is the bottom of the brainstem, and then continues into the cervical cord. So researchers, and I have all the articles here because I know people like to know where the articles are. Researchers have determined that TN pain originates from damage not only to the trigeminal nerve in the face, but also from damage to the central trigeminal system in the upper spinal cord and the pontomedullary levels of the brainstem. Therefore, trauma to the head and neck, concussive trauma to the head and neck or upper back that results in injury to the nerve pathways in the spinal cord and brain stem have been shown in medical literature to be one possible cause of facial pain. And so here's the thing, when we talk about spinal trauma, right away people go to, but I didn't have a trauma. This started in February of 2018 and there was no trauma. Oftentimes, when we see the effects of trauma in the spine, it's on average 11 years before the first symptom shows up. And that's research from Dr. Ray Damadian, who invented the MRI unit. And so 11 years prior, so then you start thinking like, was I in a car accident? Did I have a fall? Did I play high school sports? Did I play college sports? Was I abused? Was it micro trauma? Did I look at Excel spreadsheets for 30 years of my career? So there's lots of trauma to the spine. And sometimes it's so far from where the symptom shows up that we don't make that association per se. So what we know is that the human body has the ability to adapt and to heal. Ann's an example of that. There are most conditions, there are examples of human beings healing from. So lots of times we do need help from somebody from the outside, but we've got to recognize that doctors don't heal people, people heal people. People heal themselves. And so even if you have a great neurosurgeon who does a great surgery, what does the doctor say? The surgery went well. We've got to now wait and see how your body responds and heals. And that goes with everything from a chiropractic to an adjustment to a therapy. How does the body respond? How does it adapt? How does it heal? And I'll tell you that there's cases in every doctor's practice that will plateau and will need some other approach. Prescription pads can run out of pages. It can be too much for the body, too many side effects. And I don't have an opinion on the medicines because I'm not a medical doctor. I don't even pretend to be one. So I know that medicine plays a major role in patients with facial pain. I get that. I also know that people don't want to take one more medicine that they need to. No one does it by choice. But look, if I got to get a root canal, I'm not doing it without pain, without an anesthetic. And so we know that medicine oftentimes is necessary to bridge the gap to get us from here to there. And anything we can do to help reduce that load, that load is a positive. And so that's where Ann was alluding to an integrated approach. And, we had a new patient come in with facial pain, I think it was last month, and we were his first doctor. And the first thing we did was make sure he gets to the neurologist. And there's a dentist in New Jersey that works with a lot of people with facial pain, because we feel that it's important and people have a right to find out what all their options are. I almost automatically connect some new patients with Ann for this reason, so she can go through. Here's all your options. Diversity in care is very important. And it works on both ends. Like the medical profession needs to be, with these conditions, need to be open to working and with practitioners such as ourselves, vice versa. I don't know why that pops up. It goes away though. So let's talk a little bit more about what we actually do in upper cervical care and what makes it different. So what you're actually looking at is straight down through the skull. So here I have the skull. Here I have the top three vertebrae. The first vertebrae is called the atlas. It's named after the Greek god that held up your world, the world. It held up your world. And then you have C2 and C3. Now, if we turn the body on its back and we take the skull off, there's actually a hole in your head. See, your dad was right. You do have a hole in your head. And that hole is called the foramen magnum. And that's where that brainstem that we talked so much when we were reviewing anatomy before lies. It lies right in there. And it actually can, according to Gray's Anatomy, extend all the way towards C1. And so if over the course of our life, that first cervical vertebrae is aligned, that space remains nice and open, or what we call patent. And if that vertebrae is aligned, the skull sits up on top, the shoulders are level, the hips are level, the spine's not twisting, all is happy in the world, in our internal world at least. And so if there's a misalignment in chiropractic, we call that a subluxation. If there's a subluxation or a misalignment of the upper neck, if this vertebrae misaligns, and it doesn't have to be much, it could literally be millimeters, then that can put enough pressure on the upper cervical cord, because there are ligaments that attach from the C1 vertebrae to the dura, which is the sac around the spinal cord. It can traction on it, and it can throw off the postural muscles of the body, and it shows up as a tilted head, high shoulder, high hip, twisting of the body framework, and there's typically zero symptoms. And then the person walks around in this altered position for years and years, and that leads to a progressive wear and tear, and eventually a symptom can arise. It can be facial pain, it could be migraines, it could be back pain, it could be GERD or heartburn. It could be anything, because everything's controlled by this system. And when we look at the uniqueness of the upper cervical spine in the C1, it's the only vertebrae in the spine that doesn't have these interlocking joints. And it's the only vertebrae in the spine that doesn't have a disc above or below it. So it's literally free floating in here, just supported by soft tissue. So now we look at people looking at cell phones nonstop. We look at old car accidents and injuries. We look at the sports injuries. We look at the birth process. It's no telling that most people that we consult with have some sort of misalignment in their upper neck. For some people, they can go a whole lifetime and not have a symptom. For others, it can completely wreak havoc on their body. The reason why your neurologist or your neurosurgeon didn't pick up on any of this is because they don't look for it. We take specialized x-rays with specialized software and specialized protocols that allow us to assess the alignment of the upper cervical spine to 1/100th of a millimeter. That's one of the many things that makes upper cervical unique. And it doesn't mean your neurosurgeon missed anything or your neurologist missed anything. I don't listen to my patient's lungs. We all are doing what we do with the knowledge and skill set that we have. And so over time, with the twisting of the body framework, the spine starts to compress. Most people think it's normal to just get shorter as you get older, but you're getting shorter, or people are getting shorter, because of the compression. So I keep a Coke can in my office here, just like that Pepsi can in there, to paint the picture of what happens to the column. If I had a brand new Coke can, like the Pepsi can on the slide there, you can press down on it and it won't collapse. It's got structural integrity. And that's the way that the spine has been designed. Once you put a little twist or damage into the system, it compresses, it loses its integrity over time. And we can see that on an examination and on an x-ray. Eventually, again, that can show up as neuralgias or disc problems or osteoarthritis, and the list goes on. So a misalignment of the upper spine and brainstem have specific consequences for people suffering with facial pain. Upper cervical care is measurable and correctable. Not only do we rely on x-rays on the front end, we rely on x-rays on the back end of the care to actually measure objectively the change that's happening within the spine. We're going to talk about another mechanism. It's technical, but usually when I meet with patients with facial pain, they have done a lot of research and they're actually very much in the know, and they can actually sink their teeth into a little more meat and potatoes. So nociception is the neurology of the body, the system of the body that experiences pain and discomfort. Mechanoreception is the type of nerves in the body that give us a sense of where our body is in space. Nociception goes up, pain goes up when mechanoreception goes down, and pain goes down when mechanoreception goes up. They have an inverse relationship to each other. That's why when we touch a hot stove, we shake our hand, because the shaking of the hand beats the pain signal to the brain. That's why some people use a TENS unit, which fires off an electrical impulse, which that mechanical impulse beats the pain signal to the brain. Or if a baseball player gets hit with a ball, they run around and they rub their arm because that mechanoreception beats the signal. There are more mechanoreceptors in the upper cervical joint than any other joint in your body by tenfold. In fact, 60% of the brain's mechanoreception is coming from the spine, and a third is coming from the upper neck. So what I'm saying is, if the upper neck is off and the mechanoreception is down because of it, then nociception goes up. Very quickly, from adjusting the upper neck and firing and stimulating those mechanoreceptors, it starts doing this to the pain signal. So I'm giving you multiple mechanisms that are involved in the upper neck. The upper cervical adjustment has also been shown on CT scans to improve blood flow through the brainstem. That would be important. Here's the study that showed that. Possible atlas misalignment interaction with the trigeminal vascular system via increased intracranial compliance may produce neural influences on cerebral circulation. What does that mean? More blood flow following an adjustment. There's the research. Obviously, this presentation will be put up on the website, and you can pause it here and you can look at any of these articles. Here is an interesting pilot study that they did at the school I attended at Life University, where they looked at 10 people with trigeminal neuralgia over a 4-week period that got upper cervical care. And the truth is, we have numerous case reports. The challenge with being able to give you a study with 100 or 150 or 250 people in chiropractic is chiropractic doesn't receive the funding for research the way a lot of major institutions do. And so it literally comes down to dollars and cents. We did a study as a profession on hypertension and upper cervical care back in 2007 with one of the leading researchers at University of Chicago. It got published in the Journal of Human Hypertension. That one study cost $600,000, and the doctor paid out of his own pocket for the study to be done. So there is another mechanism, and this one is, I think, the most exciting right now, because we knew for years that there was a mechanism of cerebral spinal fluid coming in and out of the brain. Cerebral spinal fluid is the fluid that cleanses your brain. And I already alluded to him before, Dr. Ray Damadian is the Thomas Edison of medicine. He invented the MRI unit. Well, several years ago, about a decade ago, he invents a video MRI called Phonar. And Phonar is video MRI. Most of you who have had MRI studies, it's a snapshot of your anatomy in time. No movement. Phonar actually shows the fluid flowing through. And what he did, Damadian, is he teamed up with an upper cervical doctor in New York, Dr. Scott Rosa, and they started putting MS patients, Parkinson's patients, ex-NFL football players, ALS patients in the unit. And what Damadian found was that in 100% of the cases with these neurological disorders, people had an upper cervical misalignment that was blocking the flow of cerebral spinal fluid. And so I was thumbing through the channels during one of the Super Bowls, and Jim McMahon was being interviewed on ESPN about his upper cervical care. They do a special there, ESPN 30/30. And Jim McMahon had played for the 1985 Bears, took a lot of hits to the head. And I'm going to show you a short clip here. It's about 2 minutes of the ESPN special. So you're going to see Jim McMahon get the upper cervical adjustment, and you're going to see his MRI, and you're going to see his brain change as a result of the adjustment. I just hope the sound comes through. And so if you can just give me a thumbs up if you hear it on your end.
We were with Dave maybe 3 months before he killed himself. Okay. And to me, he was the same old Dave, whether he was a little more quiet than he usually is. He talked to me about it. He said, Maggie, it's frustrating to get in my car to go pick up my kids, and I can't figure out where their school is, or I can't figure out how to get home. But I would have never in a million years thought he could do that to himself. And then I started having the same problems. Bad headaches, pressure on my skull. I couldn't see very well. I couldn't talk very well. All I wanted to do was lay down because my head was just constantly pounding. The pain had gotten so bad where if I had had a gun, I wouldn't have been there. And these 2 doctors from New York called me and said, hey, we think we can help you. We think we know what's going on. I said, let's do it.
Jim was diagnosed with early onset dementia. He had been complaining about a brain fog, as he described it, as well as he described it, a headache where he felt like ice picking on both sides of his brain.
While most concussion studies are focused on the brain, McMahon's team traces the effects of CTE directly to the upper spine, having found that neck misalignment can block the flow of spinal fluid and pool toxic proteins directly onto the brain.
Spinal fluid is white. That's the spinal cord. This is the spinal column. What you're seeing is a narrowing of the opening where the spinal fluid is supposed to come through.
Most of the time when you're having head problems, that's all they look at is the head. These guys were smart enough to at least look below the head at the neck and see if there was a problem somewhere, and they found my problem. They're not going to be able to reverse the damage. Like I said, that stuff was sitting in there for 20 years. So how much it ate away at my brain, I don't know.
Using detailed images captured by the MRI scans, McMahon regularly receives targeted adjustments, clearing the blockage and restoring the flow of spinal fluid.
This instrument is going to generate a gentle mechanical tapping that is just lightly going to put those bones right back into normal position. Okay, I'm going to sit back up.
First time they did this procedure, within 2 minutes, it was like the toilet flush. I could feel this stuff actually leaving my brain. My eyes cleared up, my speech cleared up.
The left is before, the right is after. So you see how much there is there? See how there's less than here? Instead of all this white stuff being in there, you're seeing more brain tissue than fluid. So it's already started to brain. Over the next several days, it'll improve more.
Well, the damage is done, it's done. I can't reverse that. But what these guys do for me, they keep me from having these bad pains, having these suicidal thoughts, having me function fairly normally while I can.
So it's such a powerful mechanism. And what's so exciting about, today's day and age, when I got out of school 18 years ago, none of this technology existed. Now there's doctors who have chiropractors, upper cervical doctors who have CT scans in their office, and you can see the 3-dimensional position of the spine. It's amazing the technology is validating and showing these mechanisms that at one point were theoretical. Let me go on to the next slide here. Okay. So many of you are in other parts of the country, maybe even other parts of the world, and there are upper cervical doctors. Now, we are a specialty. So what does that mean? If they're just like law is a big umbrella term, and there's lots of different types of attorneys, same with medicine, lots of different types of medical doctors. Chiropractic is a very broad term. So even if you said, I tried chiropractic, I'd want to hear, I've already tried upper cervical chiropractic, because that's a specialty within chiropractic. Then within upper cervical, there's 8 or 9 different types of approaches, of which I've practiced 3 of them. The one that Jim McMahon was getting there was one done by instrument. They're all different versions, but we all speak the same language. It's all calculated. It's all gentle. They're typically done with the patient lying on their side so that we can access the upper cervical spine. Some are done with an instrument like you just saw. Many are done by hand, but again, there's no twisting, turning, popping, or cracking. The technique and procedure that I utilize in my office is QSM3. It stands for Quantum Spinal Mechanics 3. Other techniques that I've used earlier in my career that are equally as good and effective is NUCA, National Upper Cervical Chiropractic Association, and Advanced Orthogonal, AO. That's the one that's done by instrument. So I'm going to give you some resources so that you can look for a practitioner close to you. And it'll just warm my heart to know that this 30 minutes, 60 minutes that I spend with all of you can make an impact on your lives and your quality of life. In fact, I would love to hear back. I'll give you my contact information. This was a case study that recently came out with the work that we do on a trigeminal neuralgia patient and the effectiveness of it. Again, it'll be in there in the replay. This is what the upper cervical adjustment looks like. From a feeling perspective, it's really no more pressure than if you were going to see if a cantaloupe was ripe. That's how gentle it is. And it can be gentle because these vertebrae only weigh about 10 to 12 ounces. You know, I tell patients, I'm 180 pounds. These weigh 12 ounces. How much force do I need to use to move these? And if we're going to use leverage and mechanics, you can move a car with one hand with a lever if you have a jack. So we're leveraging in a way that makes it super comfortable and super effective. If you want to see video on my homepage, and my website's right there at the bottom of the slide, getwellnj.com. We have a what to expect video or how upper cervical works. And we have clips of me actually doing adjustments. So do you need help? Do you want a next step? I want to give you resources. So first of all, if you have a question for me, even after we get off of here, you can always text my office number and it goes to my staff. So that number at the bottom there, 732-617-9355. 9355 is well, by the way, 617-WELL. You can text your question there. It goes right to my staff and they'll make sure I get it. And I'll respond to you. I'll text you back. I'll call you. I'll email you. I'm a busy guy, but I will get back to you. I promise you. I don't ever let a message go untouched. Here are some databases of upper cervical practitioners. Disclaimer, I don't know every practitioner that exists in the world, and I don't know what your outcomes will be, and I don't know what they're going to do. But when a patient of mine says they're going to move to another part of the country, or they have a family member that needs an upper cervical doctor, unless I specifically know of a doctor close to that city, this is where I send them. So uppercervicalcare.com is one of the newer databases. And you can look for a doctor, put your zip code in and see who comes up. And it'll actually tell you how many miles away from your zip they are. Great website. UpC-Spine was one of the original databases. So when you go out to that site, it looks a little older, but it's got a lot of doctors. So those two sites may have some overlap, but may also have some different doctors on there. QSM3, which is a smaller technique because it's one of the more progressive. That's the technique that I do. We have a database on there as well. And then, I wanted to put this on there. There's a great Facebook group. Now, this Facebook group has about 2,500 members, and I would say they're probably about 95% doctors. But what I'm seeing is patients going onto that group now asking questions and doctors responding to their questions and concerns. So that's a way you can access 2,500 upper cervical doctors all at once. So that's the Upper Cervical Club, and that's a great resource as well. So there may be a couple people, maybe one, maybe two, maybe 10 that are local. and that would like to come in and meet with us in our practice. In our practice, we have 4 doctors that do this work. If you're in New Jersey, New York, or Pennsylvania, and you did want to come in, we go through a 6-step process where we'll do a full health history. We do a QSM-3 posture evaluation. We do computerized neurological assessments, 7-view digital x-rays if that's appropriate. We even check your benefits, and we do a second follow-up visit where we report all the findings. Whenever I do a presentation like this, I want to give people an opportunity to be able to come in and go through this evaluation, which is normally valued up to $340, and we do that at a reduced fee. So our special offer that we wanted to do tonight for people who are local, and there may be none of you that are local, and I'm sorry about that, but hopefully there is somebody or a few. You can text WELL to our office number, and you will get prompted to put your information in, and you'll be able to redeem that offer. That's also a QR code. You can just point your cell phone's camera to that code right now, and that will take you out to that offer as well. So that wraps up my didactic part of this presentation. My true hope from the bottom of my heart is that this lands in your heart and this leads you on a great path towards relief and/or recovery. And with that said, I will zip it up for a second and turn it over to Ann for questions.
Thank you. We have some very specific questions, but I'd like to ask a few general ones first.
Sure.
On average, how long does it take to feel relief?
That's the crystal ball question. And I would ask that too if I was a patient. And not only am I going to answer how long can it take, I'm also going to answer like, what can I expect? What level of relief? And unfortunately, like everything else in healthcare, it's not going to be black and white. So we have seen patients with facial pain get a marked reduction very quickly, within weeks of starting their care. I've also seen it take months. Now, in general terms, the longer it's been there, the more hardwired it is into the nervous system. And the longer lots of these structural changes have been there, the quicker we meet somebody at the onset of the condition, that usually lends to a better prognosis. But there's a lot of factors. There's lifestyle. There's how complicated is the misalignment. We have simple and complicated misalignments. How degenerated is the spine? So when we sit down and we do that report of findings to the patient, we give them a sort of a ballpark of what we expect based on all of those factors. As far as what we see regarding relief, I've seen the entire spectrum from complete resolution of symptoms to large windows of relief, followed by episodes of breakthrough where the pain comes back. And then we sort of work really closely again together. And then it goes into a sort of a remission again. I've also seen where it just comes down a notch, where it just comes down from like an 8 out of 10 to a 6 or to a 4. And that's saying what's kind of happened with you in the beginning, and you were able to reduce your medications, of course, with your doctor. We don't touch that. And so everything across the board. I have a patient in here now. His name is John, and he's a longtime patient because we put patients on maintenance care, and we'll check people periodically to maintain the health of their spine. Sometimes there's an episode and we have to see them more frequently. But I was talking to John and I said, John, we're doing this presentation. Isn't great. We're going to be able to, reach the whole country and introduce upper cervical care. By the way, what's your pain level now? And he said 1. And he was a 9 out of 10. He used to describe it as somebody taking a hot knife and dragging it through his cheek while he slept. And he told me that he said it took about a year. And so that's one of the longer ones. But now I've been working with him for, on a maintenance basis every couple of weeks for quite some time. And he's at a 1. So you don't know, and you can't judge a book by its cover. I've seen some really complicated cases do that, and some simple stuff just not respond the way we would want.
We have another question, and this is related to one of the questions I have. We talk a lot about benefits. Are there any risks, and does it ever exacerbate pain?
Yeah, that's a really fair question. So The upper cervical procedure as a whole is chiropractic as a whole is a very safe profession. When you want to evaluate the risk of a procedure, I've always said, look at malpractice premiums, because if something was risky, the premium is going to be high. Our malpractice premiums are less than $2,000 to $2,500 on the high end. I mean, that's like auto insurance in New Jersey. But like what medical malpractice premiums are. And so as far as the riskiness of a procedure, it's very safe. And because there's no herky-jerky motions, some neurologists will tell patients to stay away from chiropractic because they don't want the neck twisted. But you will put more stress on your neck backing out of a parking spot like this, or going to get your hair done and putting it back in a sink, than what we do in our procedure. I don't see the procedure exacerbating symptoms. Sometimes there's a one-off where perhaps just like going to the dentist, you go for a cleaning and things kind of pick up for a day or two, and then they kind of come back down. But that's a one-off. I mean, one-off. We've done thousands of adjustments on facial pain patients, and I could probably count it on one hand the amount of time someone said it flared them.
And how long do these treatments need to continue?
So that's going to be a case-by-case basis too. Generally, we look at the care in 3 parts. There's an initial intensive phase of care where we're seeing patients more frequently to help reduce symptomatology and start to change the spine and the nervous system. There becomes a point where patients are either asymptomatic or less symptomatic, but I always get nervous there that patients feel that it's all fixed and better. And sometimes if they stop care there, just like if you were to stop taking your medicine, things can return. And so the second phase of care is what we call corrective care. And those visits in the less symptomatic or asymptomatic phase is what strengthen and stabilize the mechanics. So there's a holding pattern and a recovery, whatever that recovery is for that person. Those first 2 phases are going to vary based on all those other factors: consultation, history, examination, x-rays, how much degeneration, how long has it been there. But to give you a range, it could be anywhere from 3 months to 9 months till we say, not for relief necessary, but to go through that corrective process. Most patients, about 80 to 90% of my practice at this point, are in what we consider maintenance care. Just because this is a chronic condition for most people. And just like if somebody were to lose 20 pounds in the gym and working with a nutritionist, if they were to stop exercising and eating right, it's not going to take long for that weight to come back and for the old self to return. And so regular maintenance care, which could be anywhere from 1 to 2 visits a month, and in some upper cervical offices, it could be once a quarter. It really depends on the practitioner, can maintain. And I've always said, if you just maintain it, you can stay out in front of it rather than not maintaining and then it collapsing again, and then us having to go through that whole process again. So I'm giving big, large generalities, but I am being very transparent about the process.
Mm-hmm. Okay, and this is just anecdotally, and I think you answered this in your presentation, but I'm going to ask it again. Some patients develop TN after an accident. I know personally of someone who fell off a loading dock and got upper cervical care and was fixed.
Yeah.
Or some people have car accidents. There's no end to the kinds of things that might be accidental and result in TN. It seems to me that those patients do extremely well with upper cervical. Is that true, or is that just my perception?
No, that's 100% accurate. And when I do a history or consultation on a new patient, that question comes out of my mouth almost immediately. Tell me about past traumas, accidents, injuries, even if it was a long time ago and it doesn't seem related. I mean, you can just tell I've asked that question a million times. And so when those injuries and traumas come up in the consultation, that's part of that clinical decision-making process where we go, that leads to a better prognosis if there's a past trauma and in that a significant past trauma in that person's history. And sometimes it's black and white, like, fell off a loading dock and then the pain came, and like you don't have to be a rocket scientist to say, okay, there could be correlation or causation. But lots of times, as I said, there could be a large gap between the trauma and the first symptom.
Okay. Okay, so we just got a question I think is really important. Trigeminal neuralgia is just one form of facial pain.
Yeah.
Does upper cervical help with the different types of facial pain?
Yeah. So because chiropractic doesn't treat anything. So here's the thing. I don't do a different type of adjustment for a facial pain patient than a migraine patient, than a fibromyalgia patient, than a patient with sciatica. But because of where we're working, it greatly influences it. So the classification and naming of the condition is probably more important on the medical side to determine what's the best method of medical care. But from a chiropractic standpoint, we're going to find the mechanical change in misalignment, the subluxation, and we're going to correct it, whether it's atypical, typical, left, right, bilateral, switching. So I don't think I've ever seen two cases the same as far as symptomatic presentation in my entire career. So the answer is I've seen them all respond, and I've actually retrained myself, just like the Facial Pain Association. I really try not to say trigeminal neuralgia anymore. I just refer to it as facial pain.
Facial pain, that's good.
Yeah.
Okay. Somebody asked, does it complicate upper cervical care if you have a herniated disc?
It's probably a great thing if you have a herniated disc to get under upper cervical care, because we help a lot more. I help a lot more people with herniated discs than I do with facial pain, just because there's a lot more of you. And if we go back, if you were on the presentation for the Coke can, it's the trauma to the spine followed by the collapse of the spine that causes the soft disc to herniate. So most patients with a herniated disc and a pinched nerve, they go to the orthopedist, they get the MRI, they see the herniated disc. They think that's the cause of their pain. Something caused a herniated disc. That's the cause of your pain. And it's the initial trauma that changed the position of the spine, the abnormal movement patterns, the unequal weight distribution that eventually caused that soft disc to herniate. And everybody is focusing on fixing the disc and the pain when you really got to fix the mechanics that put the pressure on the disc in the first place. So it could complicate the prognosis and the recommendation, because now on top of facial pain, you got degenerative disc disease, but you could certainly be helped. And that would be like a 2-for-1, wouldn't it?
Mm-hmm.
Yeah.
Okay. So Tom is asking, can you tell us your success rate for getting rid of trigeminal neuralgia totally?
Yeah. I get it. And this is why I put up research, because I invariably get that question. Tom, I would love to have a statistic, and Ann can testify to this. Our office sees about 80 to 120 patients a day, and I have done that nonstop now. We're blessed for years. I am such a practitioner. I am not a clinical researcher. I am not accumulating data. I'm not analyzing the data. I don't have a second to breathe. So I'm not the guy to be able to give you a statistic. I'm in the trenches just helping the people from the second I walk in to the second I go home.
And I want to say to Tom that trigeminal neuralgia has been in my life for 50 years. So I'm a third generation patient with it. And at least my experience with my family and friends I've met through the FPA is there is no magic bullet. I mean, even MVDs, which are supposed to be perfect, the gold standard, aren't magic bullets. And you need to define your own success. And
great point.
To me, my goal was to be able to drive a car again and work and take care of my children. And I could do all of that, and I could manage some pain along the way and not much at that. So, if your success is to be 100% rid of pain, you're going to have a different experience than someone who is, I think, more realistic in managing their pain by saying, if I could just take fewer medications. And somebody else did ask a question, can you reduce the medication you take? Yes, but you should do that along with the doctor that prescribed the medication.
Totally. Yeah. And we look for better, I don't ever promise a patient anything, let alone 100% pain relief. Now, when that situation happens, we celebrate. I mean, it's wonderful. I love hearing that. But we're looking for better. And I'll ask a patient, let's say we end up working together 6 months from now, what are your expectations? And and we want to make sure that there are realistic expectations, and what are your goals? And in addition to pain relief, because everybody has the goal of pain relief, what in your life would you like to see improve? For Anne, it was driving and working. And if we can get back to those things that were previously difficult, then we're winning.
We need to shut down the chat, and I'm not being able to find that. So, Anne, can you help me do that?
I need to shut down the chat. Somebody is doing something not nice.
Yeah.
Okay, but can I ask, Ernie Zebro, are you still on? Can you unmute yourself if you are? Ernie? You had a very specific question. I'd like you to still be able to ask it. Guess he's not here anymore. So somebody else, here we go. Sharon.
I'm trying to, okay, John Tanner. John Tanner is being sent out.
Okay, oh good.
Locked.
Okay.
These are my bodyguards.
Yeah.
Yeah, we're Jersey girls,
Yeah, I know.
Watch out.
When you start naming my children, I get a little bit upset.
Yeah, I apologize to everybody for that. I just saw what was going on, so I apologized for the nastiness, and I hopefully that shut it down.
Okay. We have a question about thoracic outlet syndrome. You know what that is?
Oh, yes, I do. Yes.
Okay.
Question specifically.
Okay. So do you find the connection between thoracic outlet syndrome and trigeminal neuralgia, and how does that change your treatment?
They're really two distinct conditions. They really are. And I actually haven't seen those two together ever. I've seen them separately, but I haven't seen them together. But again, if there's thoracic outlet, just so everybody knows, the nerves and the blood vessels that come out of the lower neck, the brachial plexus here, can get impinged. And those patients oftentimes will get pain or paresthesias into their arm and hand. But if there's, again, a cervical compression, we can't think of these vertebrae in the neck as separate. They're all one unit. So it is conceivable that you can be compressed in two areas at the same time. And yes, we've helped people with thoracic outlet. They tend to need therapy along with chiropractic care because there is a large muscular component where those nerves and blood vessels are getting impinged in this area. Yep.
Okay. And Ernie, are you on? Can you unmute yourself if you are and ask your question?
He says he's there, but no unmute button. Let me see.
Okay.
Let me see if I can do that for him.
Yeah.
Okay. Ernie, are you there?
Ernie, can I unmute him?
Oh, there we go. Hi.
There we go. Hi. I want to do justice to your question. I'm afraid I'll botch it if I ask it. So could you go ahead and ask your question, please?
With having trouble remembering what that was. Let's see.
You talked about.
All right. With trigeminal nerve or other cranial nerves, sometimes they get bothered by a blood vessel, right?
Yes.
Okay, so how much do those blood vessels, say, get in the wrong position, wrong shape, wrong size because they're flabby because of connective tissue disorder?
I'm a smart guy, but I'm smart enough to know when it's outside my ballpark. I do not have the answer to that. That would be a great question for a neurosurgeon who deals with MVDs, and unless Anne has some experience with that question.
I don't know. It seems like maybe they're related? I don't know. I think we'll need to ask Dr. Brown.
Yeah, that would be a great question for him, for sure.
Okay, we can definitely do that, Ernie. Thank you.